Okay, well, I'm Ben Andrews. I'm an internal medicine doc I've also done a lot of HIV work. I trained at Emory, and then I spent 5 years in Zambia before moving to Memphis. I was working for Vanderbilt in Zambia, and so now I'm at Christ Community Health Services, and I'm mentoring Josie. I'm also the HIV director for Christ Community Health Services. Today I'm going to talk about Hep C, which is actually much trendier than HIV. It's the trendiest virus in medicine. It may actually be the trendiest field of medicine if you go by the number of New England Journal articles on Hep C treatment in the last 2 to 3 years. So just an acknowledgement, I borrowed or stole a lot of these slides from the liver learning CMEs at the AASLD, which is American Academy for the Study of Liver Diseases. They have some excellent CMEs. Also, some of these slides were borrowed from Susanna Nagy from Duke when she presented at the IAS USA course in Atlanta this year. And then some of them are directly from the constantly evolving Hep C management guidelines. Just so that you see this is the Hep C management guidelines. In the guidelines, they have a disclaimer that says, do not print these out because they may change by the time you look at them again. They came out with a whole new batch of guidelines in January of 2014, then a whole new batch of guidelines in December of 2014. And it is just constantly changing. 2 to 3 times a year, these guidelines will be updated as new medications get FDA approval. So it is a hugely fast-moving field, exciting field. Medications are expensive, but they're accessible for some patients, and hopefully accessible for the ones that really need it the most. I'm going to zip through a lot of this stuff, but as far as epidemiology, there's about 2.7 million patients with Hep C in the United States on estimate, and half of them are not aware of their infection. It's a major cause of liver disease. 50% of patients with liver cancer have Hep C. 36% of patients on the liver transplant list have Hep C. Some of those it's just Hep C cirrhosis. Some of those it's Hep C with alcoholic cirrhosis, for example. Successful treatment of Hep C reduces health costs overall if you can prevent decompensated cirrhosis and you can prevent hepatocellular carcinoma, which is the big fear. This is just a very interesting slide because it shows that in 2007, Hep C overtook HIV as a cause of death in the United States. So for a long time, of course, HIV was the virus to be worried about. Now Hep C is really the virus to be worried about, at least for the time being. This is partly a temporal thing because there were so many Hep C infections in the 60s and 70s, and those patients started aging into cirrhosis and aging into hepatocellular carcinoma. And so that's why you got the increase like that. And of course, we're doing better with HIV, so that's a good thing. You see that Hep C far eclipses Hep B as a cause of death. Feel free to stop me at any time. So in the absence of new interventions, and we do have new interventions, but if people didn't get treated, this is sort of the burden of Hep C as it's projected. Deaths would probably peak around 2032 based on the sort of the cohort of when patients got infected. Decompensated cirrhosis would peak slightly earlier than that, and HCC would probably peak around late 2020s to 2030. So even in the absence of treatment, Hep C is not going to be a problem in 50 years from now, thankfully, because you're just not. I mean, it won't be a big problem anyways, because once we made the diagnosis, discovered the virus in the mid-late 80s. It's at least they can test in the blood supply and things like that. But certainly for the next 15, 20 years, untreated Hep C will continue to be a bigger and bigger problem. And this is just sort of a timeline of Hep C. The discovery was 1989. The Hep C antibody test was licensed in 1992, and you just see the incidence has gone way down, thankfully. It's preventable. It's not very efficiently transmitted sexually. So it was really IV drug use and blood transfusions that were the big driver of Hep C transmission. This is just looking at the risk factors for Hep C and the prevalence among those risk factors or risk factor populations. So if you see people who inject IV drugs, 60% prevalence of Hep C. So IV drug users, at one point it was probably even higher than that, and almost everybody that was using IV drugs had Hep C. Incarcerated persons, 35%, and that you can speculate that part of that is because of a huge overlap with IV drug use. Part of that might also have to do with sex, particularly MSM sex, which tends to be more traumatic and have a higher transmission rate. HIV infected, about 25% of people who are HIV infected, at least in previous cohorts, were also Hep C infected. Probably again because of the overlap of IV drug use as well as MSM. We're seeing a lot less than that in our population here in Memphis. Dialysis 10%, and you go on down, and people born between 1945 and 1965. This is the cohort that is the highest risk just by age for Hep C, and it's because those are the people who are in their 20s and 30s when Hep C was really, being widely transmitted in the 70s and early 80s. And so anyone born between 1945 and 1965 really ought to be tested for Hep C. For our purposes, talking about HIV and Hep C, everyone with HIV obviously ought to be tested for Hep C at some point, at least once, if not annually, and we'll talk about that. So this is a very good sort of simple algorithm. But so you've decided to check a Hep C antibody. The antibody is negative. Essentially, you could say, okay, the patient has not been exposed to Hep C, and you don't have to worry about Hep C. If the Hep C antibody is positive, then you have to determine, does this patient actually have active Hep C viral infection, or have they cleared? About 15 to 20% of patients clear spontaneously. In HIV infected, it might actually be a higher clearance rate than in HIV uninfected if you look at some series. But anyway, so when you see that they have a positive Hep C antibody, you want to then go on to do a Hep C PCR to confirm that they're actively infected. If it's negative, then the two possibilities are they cleared spontaneously or they were treated already. And obviously you can figure that out from the history. But as I said, about 80 to 85% of patients will remain infected and should have a positive PCR, in which case you link to care, which can either be you, or if you're not doing Hep C care, you can refer those. And this just shows sort of the natural history of Hep C as a breakdown of who progresses to what. So as we mentioned, 15 to 20% of patients will clear spontaneously, and it feels good when a patient comes in and they're so worried with their positive Hep C antibody test, and you tell them, actually, you're among the 15 to 20% who cleared after you get their PCR test back. But the rest, the 80% that don't clear, will essentially have a chronic hepatitis infection. And so of those, 20 to 50% of patients will develop cirrhosis. And you say, man, that's a really wide range. Can you be a little more precise? Well, that's 20% at 20 years and as much as 50% at 35 years. So it's just a steady progressive infection. So it just progresses to cirrhosis. And so probably if we followed these patients out 40 or 50 years, that might even go up 60, 70% developing cirrhosis. We don't have case series that are that long, that have followed patients that long to know. Among that 20 to 50%, if you develop cirrhosis, 3/4 will remain with stable cirrhosis and compensated. 1/4 will develop decompensated cirrhosis, which will lead to death in a large percentage of them. And there's a 1 to 4% risk of hepatocellular carcinoma per year once you've developed cirrhosis from Hep C. So it's per year. Now, I know you all had the Hep B talk last week. Hep B, you can develop cirrhosis without, you can develop hepatocellular carcinoma from Hep B without developing cirrhosis. By and large, Hep C, you typically will develop cirrhosis before you develop hepatocellular carcinoma. So you don't have to screen for HCC until you've got some indication of cirrhosis. There may be some risk in HIV positive patients of sort of jumping that, but probably not. And probably it's just maybe an increased risk of cirrhosis in the HIV positive patients, and so you might see a little bit of faster progression. So HCV treatment goals, really, it's to eliminate the presence of the virus, and it's in order to reduce liver-related morbidity and mortality. So it's both reducing the likelihood of decompensated cirrhosis and also reducing the likelihood of hepatocellular carcinoma. And I believe you all already talked a little bit about fibrosis scores last week with the Hep B talk. But anyway, so F0 is no fibrosis, F1 is a little bit, F4 or Medivir 4 is cirrhotic. 3 and 4 would be considered advanced fibrosis, definitely needing treatment. And we'll talk a little more about who needs treatment and when. And this is just showing the progression to cirrhosis. Again, at 20 years, it's maybe 15%. At 35 to 40 years, you're talking about close to 50% of patients developing cirrhosis. So it is very progressive. This is a good algorithm for assessing the severity of liver disease. If they have an HCV RNA positive, and so you know they're infected, of course you do a history and physical. If they have obvious stigmata of cirrhosis, then they're cirrhosis, and they're usually called Medivir 4. If they have platelets below 100,000 without another obvious cause, with AST greater than ALT, we just go ahead and call that cirrhosis. If they have cirrhotic liver on imaging, either nodular shrunken liver or an enlarged caudate lobe of the liver, you would call that cirrhosis. And there's no need for further fibrosis evaluation. Otherwise, you want to try to get a fibrosis evaluation. And I believe you all already had it circulated last week, the FIB4 and the APRI scores. But those are sort of the easiest to do, because if you have a CBC, so you have somebody's platelets and you have their AST and ALT and their age, you can calculate a FIB4 and an APRI score, which can be a good rough estimate of their fibrosis levels. There are other ways to test as well, and I'll show you those here in just a second. We won't talk much about clinical features of HCV because they're basically the same as clinical features of Hep B. But the extrahepatic manifestations of Hep C, some of these can also be similar to what you might see in Hep B, but the things to note, cryoglobulinemia, which can cause vasculitis and it can cause other problems, is not uncommon in Hep C. I've seen 2 patients in the last month or so who are Hep C mono-infected who had cryoglobulinemia. Then certainly renal manifestations similar to Hep B, so proteinuria, dermatologic disease, diabetes or worsening of diabetes, ITP, other autoimmune disorders can flare or have initial onset due to Hep C. And with the vasculitic disease, you can get cerebral vasculitis as well. Just a lot of various pro-inflammatory problems.